4-year-old boy. His name is
Mm.
4-year-old boy. His name is Sam, and your command is to look at this child. I'm sharing the picture with you. Okay, you can put that on the screen. I'm sharing on your WhatsApp. Okay,
Mm. Mm.
do his cardiovascular examination. This is your task.
Okay, serious.
Just
Okay.
actually, I'm nowadays with you. I'm a bit more interested in CVS.
Okay.
When you're ready, just let me know, and you can then start. Okay.
I can start in 10 seconds only.
Okay.
Okay, we will start the UNE, but you have to reply fast my questions so that we will finish in time.
Okay. Right.
Okay,
Start.
let us start. Hello, good morning. This is Dr. Pankaj. I would like to examine SAM. Is that okay to you? I am looking at the SAM.
Yes.
Thank you. And washing my hands. And I would like to know his height, weight, whether he's distressed or comfortable. Any special features I don't see, and any attachment he has brought with him. Oxygen.
Height weight below third centile. Oxygen not attached, and there is no device connected.
Okay, oxygen
Not
saturation.
distress.
Okay,
Oxygen saturation. Pulse oximetry. It shows uh, 84.
81 in air. Okay, I
Yeah.
would. Okay, Sam. Hello, Sam. So I would like to see at 45 degree he's lying on the couch and he exposed in the upper part. I'm just want to see his
Okay.
hands. So Sam, could you please open your hands? Show me your hands. Hmm. So both the hands I'm looking for
Okay.
the clubbing, which I can see. I think yes, clubbing is there bilaterally. Cyanosis
Yes.
also I can see. Pallor is there.
Okay.
Not visual. Pallor is there.
Yes. Mild.
Okay, pallor is there.
Mild pallor.
Then I would like to in splinter hemorrhage, general lesion, Hostler knots.
No.
No. Okay, cannulation marks are there, recurrent.
Yes. Yes.
Okay. Uh, then I would like to see pulses bilaterally, right and left hand. So what are the rate rhythm and character of the pulses?
Yeah. Pulses are okay.
Okay, then I would like to check his blood pressure in four limbs.
No need.
Okay, then I would like to go up and we'll ask him to pull down the eyes. So is there a jaundice, pallor in the eyes or
No.
congestion?
Yeah. There is congestion.
Okay, now I will ask him to open your mouth, please. So I can see there is a cyanosis, dental carriage, high arch palate,
Yes. Yes. There
that,
is
that
cyanosis. You can see.
dental carriage and high arch palate is there.
Yeah. Poor oral hygiene. Arch is normal.
Okay. Now I would like to do inspection from three sides, right, left, and from the bottom. So I would like to see for the side shape, symmetry, scar, any distress, any apex bit visible, impulse. So is there any finding?
Yeah. Yeah. There is mild bulge of the left hemithorax. There
Okay.
is no scar.
Okay, no scar. Okay. Now I would like to go check his JVP. So what about JVP? We'll measure.
Uh, no need.
Okay, now I would like and would like to palpate the chest. So I'm putting my both the hands over the lower part of the chest, then upper part, then my ulnar border of the lower left sternal edge. So can I see the uh, heart on the left side?
Yes, heart is on the left side.
Left intercostal space. So I would palpate the spaces 1, 2, 3, 4, 5. So apex between which ICS.
It is in the left fifth intercostal space,
Okay, it is not displaced,
just
no
just
bound. Hmm.
just just lateral to the mid clavicular line.
Okay, and now I would like to any parasternal heave.
Yes, there is right parasternal heave.
Okay, any this thrill in the upper part of the chest.
Yeah, there is a thrill.
Okay, in the
Left
sternum.
left upper sternal border.
Okay, and then the neck, I would like carotid thrill is present. I would like to palpate one by one.
No, no.
Okay, thrill in the left. Now I would auscultate the chest from the this mitral area, tricuspid area, pulmonary area, and aortic area. So I would like to see
Mhm.
S1, S2, and then any murmur, then grading, and whether it is radiating to the axilla or it is inspiration, expiration, leaning forward or not.
Yeah, there is a murmur in the left upper at the left upper sternal border.
Hmm,
It's 4/6. The
okay,
systolic murmur.
okay, and S2 is
Yeah, S2 seems to be a bit prolonged, harsh.
I mean S1, S2, S2 is split, P2, A2 is splitted.
Yeah, the pulmonic component is a bit harsh.
Okay. Okay, now I would like to check his liver. So whether his liver is large and tender or not because of higher for the this right heart failure.
No,
Okay, I would
no.
like to go down and see in the legs any edema, clubbing, cyanosis.
Okay, okay.
Well,
I have sent you murmur. I have sent you murmur. Listen to that also. This type of
okay.
murmur is there.
Is it going radiating to back? Back side I am checking.
Yes,
Which it is.
it's present. It's present all over the chest as well as to the back.
Okay. Okay, 1 second. Let me check. Okay. Okay, so today I examined Sam, 4-year-old child. He looks comfortable at rest and he is on third centile. Would like to plot him on appropriate growth chart. Uh, should I summarize, right?
Okay, okay. Continue. It's your show.
Yeah, so I would like to summarize. So 4-year-old child, he looks comfortable. He is on less than third centile for his height and weight. Would like he is looks sinus, central cyanosis and peripheral cyanosis present. He is having mild pallor. Oxygen saturation is 84 in air. And on examination I found that there is a bulging of the chest on the left side. On palpation I found that the heart is on the left side on the fifth intercostal space, slightly displaced. On auscultation, there was a thrill in the left upper side of the chest, and on auscultation I found that the S1, S2, so S1 is normal, S2 is splitted, and there is a grade 4/6 murmur thrill in the second left intercostal space, which is radiating to the back. Liver is normal. There is no edema. In order to complete my examination, I would like to check blood pressure in four limbs, oxygen saturation in four limbs, radiofemoral delay, and would like to plot him.
Okay. So, what is your diagnosis based upon your findings?
Yeah, so my most would like this is a Cyanotic heart condition, congenital cyanotic heart condition. Most probably maybe tetralogy of Fallot.
What will be your differentials for this case?
First will be tetralogy of Fallot.
Okay.
Then next it could be pulmonary stenosis, but the child is 4 years, so would have been diagnosed earlier if it is a severe pulmonary stenosis.
Mm-hmm.
Then third, it could be then
Can it be Epstein?
Epstein can be, but then there will be JVP raised, and JVP was normal in this child.
How you will check JVP?
I will ask the child to sleep at 45 degree and will check where is the pulse, and then
For example, the examiner does not know about JVP. So is there anything else you could tell him that this is not Epstein because of this?
yeah, I would palpate the liver and will see an hepatojugular reflex is there or
Yes. Yes. So you mean to say that the child should be signs of failure, right heart failure.
not. Yes.
Can 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 TOF go into failure?
Sorry. Top.
Tetralogy of Fallot,
Yes.
can it goes into failure?
Yes. Yes. If the pulmonary stenosis is going to be very means pressure is increasing across the wall.
Okay.
Then,
Which variety?
and
Which variety?
then supravalvular and valvular.
No, no. I mean, which type of tetralogy of Fallows they goes
Yes.
into failure?
Okay. Infundibular.
There are how many types of tetralogy of Fallows?
Tetralogy, no idea, not much idea.
Okay. Okay.
Infra,
What are the complications of cyanotic congenital heart?
yeah, so there is growth failure. Number two, thromboembolism. Uh,
Okay.
then that can lead to stroke,
Mm-hmm.
and then infective endocarditis.
Mm-hmm.
Mm, yes. What else?
Okay. How you are going to investigate this child?
Yeah, I would like to involve my consultant and cardiologist, and would like to send him for with the permission of consultant. Will do echo will be diagnostic, in which I am looking for the right ventricular hypertrophy and
Good.
pulmonary stenosis and VSD,
Mm-hmm.
and then overriding of aorta. Then would like to do X-ray. X-ray, I will see the boot-shaped heart with
Mm-hmm.
pulmonary allogemia. Then
Okay.
would do the ECG, in which I will see the right ventricular hypertrophy. And
Very good.
then
Okay.
I will see the hematocrit also by doing
Mm-hmm.
red blood count. So CS.
One of
Mhm.
the examiner ask you that I would like to do blood gas. So what you will find in blood gas of tetralogy of Fallot patient?
I will see the metabolic acidosis.
Very good. Okay. Okay. This child has murmur all over the chest. What can be the cause?
This is because of thrill 4/6, which is because of pulmonary stenosis. So pulmonary
No, but that should be present only in that area. Why all over the chest?
because of gradient, high gradient across the wall.
No.
And then VSD along with that VSD, but VSD will not show the murmur.
Okay. Okay. It is. I have a lot of question. Actually, your time is up, but I want to finish the topic. So the question which I have written with me, I'll just go through that. Okay.
Okay.
So and I'll answer eh, along with it because then I may forget later on.
Mm,
So it is because MAPCAS,
hmm?
because the major aortopulmonary collaterals. So because of that collaterals, the blood is flowing everywhere. Because this child is not, repaired up till now, 4 years age.
Mm,
So a lot of collateral arterial circulation have been developed. So because of that, there is a murmur all over the chest. Okay. Why you do not hear the VSD component murmur?
Okay, because of pulmonary.
Because there is also VSD, but you hear this murmur, which you said this is a pulmonary outflow murmur. So why you hear this murmur and why you don't hear VSD murmur?
Because pressure across the pulmonary wall is much bigger than the VSD. I mean, septum across the septum. Pressure gradient.
Very good, excellent. Because the pressure gradient across VSD is low as compared to that of the other one. Excellent. Okay, so how you're going to treat the TET spells?
Yeah, TET spells, I will admit the child and will keep in knee chest position first. Then we'll give high flow oxygen. We'll put IV line. We'll give morphine or any morphine or analogs.
Mhm.
Then we'll give him beta blockers. And then if there is metabolic stenosis on,
Okay.
sorry, metabolic acidosis on
Anything else?
gases, then we'll give soda bicarb.
Very good.
Yeah.
Okay, if what are the palliative treatment for tetralogy?
We do palliative surgery, BT shunt,
Very good.
the left thoracic shunt,
Oh, no, how many types? How
BT,
many types of BT shunts?
BT shunt, two types,
Okay, which two?
modified and conventional.
Very good. Very good. Okay, when the repair should be done, total repair, what is the ideal age for total repair?
It is 4 to 6 months, 6 months.
Okay, okay, good.
But if
Okay, I asked you one question that what are the types of tetralogy of fellows? So basically there are two types. One is the blue top and one is the pink top. Okay,
okay, okay.
so it's the blue top, it will never go to CCF. Okay, it's only the pink top which will go into CCF. So this one is a blue top, so very rarely it will go. But sometime the blue top can also go into CCF. So what will be that cause? Very rarely, if that is a cardiologist, he can ask you that question, but otherwise, I doubt.
So congestive.
If there are very, if yes, yes, yes,
Yes, yes, can you repeat your question? What you said? Blue top.
I said, I said the blue top will never go into failure, cardiac failure. Only the pink top will go into cardiac failure.
Mm,
So there are some condition in which the blue top can also go into failure. So what are those?
mm, mm. Yes, yes. So,
I have discussed this with you before.
mm, so blue
I
top
won't ask that much, but just
because of critical pulmonary stenosis.
yes, just remember that for blue top to go into CCF, either it should be a very large collaterals, okay, or it should be infective endocarditis. So these two, just remember these two.
Okay.
Okay. What was the type of murmur which you heard, which I sent you?
Yeah, there one was
I will share.
ejection systolic murmur,
Very good. Very good.
and there was
Very
a
good.
splitting of the S2. S2,
Yes.
splitting of S2.
Don't comment on difficult things. Honestly, I cannot pick this splitting of S2 here. But at least for me, it is a very classical ejection systolic murmur. So I'll just talk about that. Okay, for example, this is Epstein anomaly. Okay,
Mm.
so in what thing you will be interested in his ECG?
And it's P wave.
No. Okay, I make it simple. Which arrhythmia you will expect in this child?
Which arrhythmia? In Epstein anomaly?
Excellent. Yeah, Epstein. Yeah, sorry, I said you answered. Yeah, Epstein anomaly. It's a good examiner, don't worry.
Epstein anomaly arrhythmia.
Epstein anomaly. Your consultant asks you to do ECG because I want to see some arrhythmia. So,
Atrial
what do you think
arrhythmia.
that which arrhythmia he wants to?
Atrial or what?
No,
Ventricular then. No, no idea.
no.
Uh,
WPW, bhai.
okay. But oh, yes, yes. Sorry, sorry. Yesterday I read. Oh my God. Yes, yes, sorry. Correct. WW
See,
can
this
be
is
seen
this,
in
this is
external.
the refresher course.
Yes, yes. Yesterday only
It's
I
a
read.
refresher course for you. Okay, yeah, I think these are all the cases. I just repeat the text well. Oxygen inhalation, knee chest position, morphine, the phenylephrine, indrol, IV, dormicum, or what you say? Uh, what is that dormicum?
Beta
I don't
blocker.
know. Just to read.
Beta blocker.
Yes, just to reduce
Midazolam.
yeah, midazolam. Yeah, thank you, and soda bicarb. Okay, and just to reduce the acidosis. So these are the things. Yeah, anything else somebody want to add in? I think these are the all questions which I have collected, which have been asked on different forums whenever there had been a case of tetralogy of Fallot.
With your permission, Akhtar, if you allow me, I can add some comment.
Yeah, please, yeah.
During the examination, he should have covered the exposed patient, and he should have at least thanked to the family or the patient before starting the description of the case. And in the history, he should have probed for the systemic inquiry to rule out the complications like thromboembolic phenomena, brain abscess. And in the abdominal
Yes.
examination, like in the hand, he checked for the sublingual hemorrhages. He checked for the failure. He should have checked for the splenomegaly at least. And in differential diagnosis, he could have added Eisenmenger syndrome. And because Eisenmenger can also present with the central cyanosis and clubbing and a murmur on the parasternal borders.
Yes, but 4 years age, I think that is less likely. Eisenmenger, 4 years.
Eisenmenger, like if unoperated VSD, if resulted in the pulmonary hypertension and the reversal of the shunt from right to left can lead to the Eisenmenger at the age of 4 or 5 years, not an issue. Yeah.
Yeah,
Frequently,
actually,
and
what what I have seen in cardiology, because I have worked a lot in cardiology, usually it
mm,
takes at least 8 9 years to develop Eisenmenger.
yes,
But anyhow, yeah,
okay.
anything can happen. Yes, you're right. Anything can
Yeah,
happen.
like in the Down syndrome with the AVSD, usually the pulmonary pressure, the pulmonary hypertension develops a bit earlier. So it could be
Okay.
kept in the differential diagnosis. My point, I might be wrong.
Yes,
And
yes.
the rest was okay. The discussion was excellent.
Differential diagnosis, like just you should be thinking of Epstein, because MRCPCH is not a difficult exam actually. I mean, you just need to say the common things. If you say something uncommon, then you will be creating difficulty for yourself. Like if they're asking you the differential diagnosis, so simply you can say that this is either Epstein anomaly, okay, or talk about the other, like for example, you can say it may be a tetralogy of Fallot, or you maybe say it may be a TGA with the VSD or pulmonary stenosis. I mean, it can be a complex congenital heart. Simply you can say, because I remember there was one case in India somewhere in station, and I was reading the feedback there. The student, the candidate, he talked about it may be a TGA, it may be a complex congenital heart disease, for example, a TGA with VSD with pulmonary stenosis, and they accepted. And also, it may be a complex congenital heart with ASD and PS. Yes, two things can be there.
This is good
So you
diagnosis.
can say, but at least, yeah, but at least at least the common should be common and first, and rare should be rare and last. So common here is tetralogy of Fallows, followed by Epstein, and followed by, yes, complex congenital heart of any of these you can say, and they will accept it.
Mm,
Okay.
yes,
Thank you.
this includes everything.
Okay, Dr. Pankaj, thank you for joining.
Thank you.
There will be, if I got time at later on